As we know, one of the important cause in decreased vision after normal cataract surgery is the cystoid macular edema. So today I'm going to present the prophylaxis of this post-operative cystoid macular edema. I am Dr. Mohammad Tariq Khan. I work as a VR consultant at LRBT Hospital, Lahore. Now if you see, what is CME? It is the collection of the fluid at inner nuclear and outer plexiform layer due to increase in the vascular permeability caused by prostaglandins, and if the vessels are themselves already pathological, so even a low dose of prostaglandin can cause this leakage and lead to CME. Incidence of CME is 12% in an uneventful cataract surgery, with the onset as early as 2 weeks and as late as 4 to 6 weeks. The incidence is more in predisposed patients. In the pathogenesis of surgical CME or the post-surgical CME, the trauma is the leading cause. Trauma to the iris, a physical trauma or a psychological trauma. The physiological trauma, it leads to the damage to the cell wall. This releases the phospholipids, which is converted into arachidonic acid by the phospholipase. This enters into either the cyclooxygenase pathway or the lipooxygenase pathway. When it enters into the lipooxygenase pathway, it produces the leukotrienes, which are responsible for the pain sensations, the vasodilation, and the inflammatory response. When it enters into the cyclooxygenase pathway, the end product are the prostaglandins, and these prostaglandins, they produce a damage to the vessel wall, thereby increasing the leakage and causing the CME. Now I've said that patients who are predisposed to this condition are the one which have the ocular vascular disease, they have hypertension, they can have cardiovascular diseases, and smoking itself is a known entity or the known cause of this CME. The other risk factor are the uncontrolled diabetes mellitus, the diabetes itself, even if it is controlled, inflammatory disease of the eye, the uveitis, if the patient is stressed, there's prolonged surgical time, which might increase the anxiety of the patient, or if the patient is having type A personality or is already having anxiety. This can increase if the atmosphere in the theater is tense, like if the paramedical staffs are not working and the surgeon is asking for something, that thing is not available, the patient is under local anesthesia or topical anesthesia, he can listen what is happening and the patient becomes anxious. Another important thing is when you pour the adrenal solution into the infusion, amount of adrenaline can also increase the chances of CME. Intraoperative complications like PC rent, anterior vitrectomy, excessive handling of the iris will also increase the production of prostaglandins and thereby causing CME. Now the major complaint of the patient is decrease in the sharpness of the vision. Now, I remember patient used to say, "Well, doctor, although I can see all the lines, but the vision I had in the immediate post-operative period was better than what I see now." But since the available of the non-steroidal anti-inflammatory drugs, especially the nepafenec acid, I don't face this kind of complaint anymore. Now we come back to the chart. You can see that the steroids, they inhibit the phospholipase, so the amount of arachidonic acid which is going to be produced will be less, so it cannot enter into either of the pathway. So the leukotriene and the prostaglandin production will be less. Now if you see on the side of the chart, the NSAIDs, they block the cyclooxygenase pathway, thereby decreasing the production of the prostaglandins. So if we decrease the production of the prostaglandins, we can decrease the incidence of CME. We can use either steroids or we can use the NSAIDs. The different classes of ocular NSAIDs which are available are the indoles, phenyl acetic acids, and alkalones. Now, why do we use these NSAIDs? The NSAIDs are used to prevent the intraoperative miosis, as they have analgesic properties. The pain is decreased. It can also decrease the amount of inflammation peroperatively and in post-operative period, which in turn can prevent the production of CME. Now, what is an ideal NSAID? The ideal NSAID should be the one which reaches well to the target organ. It can reach the target organ both in anterior and the posterior segment. It should have excellent anti-inflammatory action. It should have good analgesic properties. It should be corneal friendly, and it should be well tolerated by the patient. The available NSAIDs for the ocular use are diclofenac sodium, flubiprofen, ketorolac, and the nepafenec acid. Nepafenec is a new drug. It is a product which, on hydrolysis by the hydrolase enzyme, is converted into the active drug which is called the amphenec acid. This increases the corneal penetration, and high levels of amphenec acid is available in the anterior as well as the posterior segment. Now, if we plan to use these NSAIDs, what is the treatment regime? The treatment regime in a predisposed individual is to start 1 week pre-operatively 3 times a day and continue it for 4 to 8 weeks post-operatively. In non-predisposed patient, you can start 1 or 2 days before the surgery and continue for 2 to 3 weeks. Now, there have been studies in which they have combined the NSAIDs with steroids. So it's a kind of using a double blocker which blocks the phospholipase and the cyclooxygenase. Now studies have shown that people have used ketorolac plus prednisolone and naproxen plus steroid, and both of the studies, they have shown 0% CME. Now I'll show you some of the slides. If you see this first slide, this was the post-operative case. Here the patient's vision was 624 with a retinal thickening of 565, and with the use of Navanic for 1 month post-operatively, patient's vision improved to 6x and the retinal thickness decreased to 214. Now remember, here the vision is 6x, which is quantitative vision. This patient might not have a qualitative vision of 6x. So in second case, the patient had anterior vitrectomy, IOL was placed in the back. Patient's vision did not improve, and the OCT showed retinal thickness of 584 microns, which decreased to 361 in 1 month after the use of Navanic. This patient was steroid responder, so after 1 week the steroids were taken off and the patient was only on Navanic. The next case is a case of vasculitis, an inflammatory disease of the eye, which developed the CME and the retinal thickness increased to 681, which decreased to 164 with steroids and Navanic eye drops. So non-steroid anti-inflammatory drugs can be combined in inflammatory eye disease also along with the steroids. And the next case is pseudophakic. Again the retinal thickness was 690, which decreased to 262. Now these are the cases, the slides you have seen are the cases in which the non-steroid anti-inflammatory were not used preoperatively. These were the cases, they came up after the cataract surgery or because of the inflammatory eye disease, that the vision is not improving, and when we did the OCT, we found that there was increase in thickness of the retina and patient was having CME. So we started with non-steroid and inflammatory, and the patient did respond. They did respond. These non-steroidal can be given in the diabetic macular edema also, when you're doing the laser, or you're giving a Western in which there is no vitreomacular tractions. So in those they also have good results. Now before ending my talk, I would like that even if you don't use this non-steroidal, the patient might not develop CME, but if he develops the CME, the quality of the vision might not be that which we would expect when there was no CME. So to prevent the CME is important, which can be prevented by using the non-steroid anti-inflammatory. Either you can use ketorolac, you can use Navanic or other non-steroidals, but you can combine this non-steroidal with the steroids. You can take off the steroids early, and within 3 to 4 weeks you can also stop the non-steroid inflammatory drug. Thank you.